Hello, good afternoon. Good afternoon, everybody. Good evening. Sorry for the delay for 7 minutes because we had some issues with the network where Dr. Prasanna's network was a bit slow. Now we have got everybody on board. So, welcome to the classroom. So, what is this classroom? This is an online initiative to bring together the neuroanesthesiology trainees as well as the experts all over the world. In fact, country, the experts will be coming in and giving their expert opinion so that we can have an interactive discussion at the convenience of your home, at your mobile device, at a PDF, over a cup of coffee or juice, whatever you want to have, you can have. And more importantly, we're going to learn an important topic today. And before that, I would like to congratulate and I would like to thanks all my well-wishers who supported me when I said interact all the neuroanesthesiology and critical care trainees and start such a program with eminent faculties. I thank you all. And today's topic is clipping of cerebral aneurysm. It's a very important topic, in neuroanesthesiology practice. We need to know about the disease, the pre-anesthetic assessment. We need to know about conducting the safe conduct of anesthesia in these kind of patients. And also we need to know about the post-operative care, and also we need to know any additional monitors which we can use to reduce the patient's morbidity and mortality. And presenting you today is an eminent speaker in the neuroanesthesiology circus, an eminent personality who's a close friend of mine, Dr. Prasanna Bidkar. After graduating from anesthesia from Mumbai, he moved on to NIMANS for a few months of training in neuroanesthesia. Later on, his formal training of neuroanesthesia and his degree of neuroanesthesia he obtained from All India Institute of Medical Sciences. And from where he moved to Sathya Sai Medical College. And from Sathya Sai Medical College, he is now settled in GIMR. He is now an associate professor of anesthesiology in GIMR. He has got few publications to his credit, but more importantly, he is an eminent clinician. He is a very good teacher, and he has possessed lots of skills in neuroanesthesia. And he is most popular among his students. So let me introduce Dr. Prasanna Bidkar to you. He is in front of your screen. And let me also introduce the eminent speakers, eminent experts today. First is Virendra Jain. He is a senior consultant in neuroanesthesiology from Fortis Memorial Hospital, Gurgaon. And Dr. Manish Marda, he is a senior anesthesiology from Fortis, Noida. Without wasting much time, let's go on to the presentation from Dr. Prasanna. Dr. Prasanna, over to you. You may start your presentation.
Yeah, thank you, Dr. Punaya. Am I audible, Punaya?
Yeah, you are very much audible. You can go ahead.
Yeah, thank you, Dr. Punaya, for those kind words. And without wasting much time, let me be a part of this great initiative by you. And let me begin my presentation. Perioperative management. As you know, it's always a challenge to the anesthesiologist to manage these kind of cases. And I hope my institute network supports me in this endeavor for the next half or so in explaining you the anesthetic.
Dr. Prasanna, can you make it full screen?
Yeah, I am doing it. Just I am giving the introduction.
Okay.
Hope my institute network will support me in this. And anyhow, great job, Punaya, and congratulations to you. So let me begin by the introduction. So the subarachnoid hemorrhage, what we know as the collection of the blood between the arachnoid meter and the pyometer, that's a subarachnoid space, is an acute cerebrovascular event. It's an emergency, and it has a devastating effect not only on the central nervous system functioning, but it influences almost all the other systems in the body. As we know, brain is the master control of all the other organs in the body. It influences so. Also, there are several advancements in the diagnosis and the treatment of this over a period of last 2 to 3 decades, which have drastically improved the outcomes in this group of patients. Still, it remains a dreaded emergency which needs to be treated as early as possible. Also needs to have a multidisciplinary management of these patients for the better outcome in these group of patients. So what are the causes? When we look at the causes, what it causes, the trauma is the most common emergency what you get, and the traumatic subarachnoid hemorrhage is the most common sort of subarachnoid hemorrhage we see in our practice in trauma patients. If we exclude the trauma patients, in the patients who are of non-traumatic origin, that means the arisal of spontaneous subarachnoid hemorrhage The ruptured intracranial aneurysms are the most common cause. They constitute nearly 75 to 80% of the patients presenting to us with a spontaneous subarachnoid hemorrhage. That is the reason we are most interested in this management. So when we look at this, it is the most common cause of subarachnoid hemorrhage, excluding the traumatic stage. The peak incidence is around 5th to 6th decade. What is more important is two-thirds of these patients who have subarachnoid hemorrhage, they get to the hospital. That means by the time they reach the hospital, we lose almost 30 to 35% of the patients. That means either they are severely disabled or they are dead. And the re-rupture incidence is much higher once the aneurysm is ruptured. That is the reason either we need to clip it or coil it for the permanent treatment of these aneurysms. So when we look at the overall incidence, it is around 10 per 1 lakh persons per year. That's around, it accounts around 3 to 5% of all strokes. So it's a part of a hemorrhagic stroke. All the others are the most common one are the ischemic strokes. And the factors, two most important risk factors for this, apart from the genetic causes, are hypertension and the alcohol use. So we need to be very careful when we are eliciting the history whether these patients are hypertensive or they are taking alcohol. So when we look at the etiology, either the congenitally the vessel wall itself may be weak, which may give rise to the formation of aneurysm, or in combination with the other risk factors like hypertension, smoking, increasing age, or a trauma or infection, all can lead to a formation of an aneurysm. So what are the location and types? When we look at this and get a pointer for you, yeah, laser pointer, come on here. So you can see the anterior communicating artery aneurysms are the most common one, followed by the MCA aneurysms, what we commonly see in our practice, then the posterior communicating artery aneurysms. So when we look at the circle of Willis, so this is the internal carotid artery on the both sides, which divides into anterior and internal carotid artery, which divides into anterior and middle cerebral arteries. And these two anterior cerebral arteries, they unite to form an anterior communicating artery. This is where the most common location of the aneurysm is present. What we call it as a anterior communicating artery aneurysm, which we are most seeing in our practice. Then this MCA, this divides into two branches. So this is the MCA bifurcation aneurysm, and the ICA, which is divided into AC and MCA. If it comes here, it is called ICA bifurcation aneurysm, or the posterior communicating artery here, which joins the two posterior cerebral arteries. At the origin of this is called the PCOM aneurysm, or the aneurysm may be located in the basilar artery bifurcation, which is called as basilar bifurcation. So these are the most common aneurysms which we get as anesthesiologists. So how do they present actually? So this the presentation is the patient typically as the worst headache of his life. This is something we can very easily classically elicit. The patient says, I have never experienced such type of headache in my life. This headache is worse than what a wife gives a headache. So you can ask whether it is routine like wife gives a headache or it is much more than that. So this is a worst type of headache, followed by there can be a loss of consciousness in this group of patients. Once the aneurysm ruptures, there will be a rapid rise in the intracranial pressure, which causes the drop in the cerebral perfusion pressure. So when the intracranial pressure goes more than the cerebral perfusion pressure, that is the time the patient develops a loss of consciousness. So this rise in pressure itself limits its bleeding. Hence, there will be gradual reduction in the ICP and the return of consciousness in this group of patients. So the patients can have a nausea vomiting because of the raised intracranial pressure, or few of the aneurysms can cause cranial palsies. Raised intracranial pressure itself can cause a rectus palsy by compression of the abdomen. And there can be a local rigidity because the blood is there in the CSF system, and there can be a warning headaches. That means patient can say initially I had a few headaches, it was not that severe, then I got a suddenly severe headache. So there can be a warning signals also may be there. Rarely patient can present seizure and fever in this group of patients. So these are the classic history one can elicit in a patient who presents with subarachnoid hemorrhage. So how do we diagnose? So this slide itself summarizes the whatever the availability of the modalities of the diagnostic procedures available for the diagnosis of the aneurysm. So I'm not going into detail of it because it itself is a separate discussion. So distal subtraction angiography is the gold standard for the detection of the aneurysms in the intracerebral vessels. Nowadays, most of the surgeons, the younger ones, are used to use the CT angiography or MRI angiography. So alternatively, even for the aneurysms more than 7 mm, either CT or MRI angiography can also be used as an alternative to DSA for the detection of these aneurysms. So how anesthesiologist involved in the management of this group of patients? So either in the emergency room, or he may be required for the transportation of the patient from the area to the hospital or within the hospital, from within the hospital ICU to the CT MRI suites where the diagnostic procedures are going to be done, or a therapeutic intervention, or surgery as such, and the post-op critical care. So the post-op critical care is also an important aspect of management of these aneurysms. So when we look at the overall perioperative management, each of these steps are equally important. Preoperative evaluation of these patients, intraoperative management, and also the post-operative care. The post-operative care, as it is given in bold, which is most important for the outcome of this group of. So what are our concerns when we look at the subarachnoid patient? So if we do not treat the aneurysm immediately, so it has a very high risk of rebleeding. Around first 24 hours itself, it has a high risk of bleeding of 4%, and subsequently it comes to around 1.4% per day. Or because of the presence of the blood, the heme itself can cause vasoconstriction and thus can lead to cerebral vasospasm and the ischemia of the brain, or the raised ICP features may be there which can compromise the cerebral ischemia and cerebral perfusion pressures. 20% of the patients of subarachnoid hemorrhage develop a hydrocephalus necessitating a shunt. So you have a gradual drowsiness or a loss of consciousness. You don't know whether it is a rebleeding or hydrocephalus. So we need to have a differential diagnosis in mind. And also, because the sympathetic surge which causes lead to cardiopulmonary dysfunction, and other hormonal disturbances can lead to electrolyte disturbance and impaired cerebral autoregulation in this group of patients. These are the cross concerns what we are going to have. So what are the information when we are going to get? The family history is most important because this runs in the families. So there can be a family history of aneurysm present in the families. There can be associated disorders like Ehlers-Danlos syndrome, neurofibromatosis, polycystic kidney disease. So these are the patients who are at high risk for the development of aneurysms because of the genetic causes. And plus, smoking, hypertension, alcohol, or illicit drug use should be elicited whether this patient is having any of these things, which predispose to the development of aneurysms. So in the examination, GCS score still remains the most standard. The worse the GCS, the worse is going to be prognosis. So initially, when the patient presents to you, GCS may be depressed transiently, and over a period of time, it may improve. And it is one of the still important predictor of the outcome or severity in this group of patients. So examination eye is equally vital because GCS does not involve, it's one of the drawback of GCS, examination of the eye. So the monoocular blindness can be caused by a large ACOM or ophthalmic aneurysm which is compressing the optic nerve. It can lead to a monocular blindness, or posterior communicating artery aneurysm can compress on the third cranial leading to the ptosis, or the uncal herniation can lead to all these findings: dilated pupil, ptosis, and ophthalmoplegia. So eye examination is an important find of any neurological examination, including subarachnoid hemorrhage patient. There are 2 to 3 grading systems which have been commonly used in patients with subarachnoid hemorrhage and the management and and to predict the outcome. So it's based on the GCS. By large, it's based on the GCS 15, 13 by 14, 13, 14 with motor deficit absent or present. So whatever it is, the grading, the worse the grade, worse is the prognosis. Recently, an exclusive GCS based grading system has been devised, which has found to be equally efficacious as the WFNS grading. So worse is the GCS, it's going to be poor. Prognosis is going to be poor, and the intensive management needs to be more and more in these group of patients. So there is one good old classification still commonly being used by Hunt and Hess, who modified a original Botwell's classification of the subarachnoid hemorrhage patients. Grade 0, grade 1. Grade 0 is an unruptured aneurysm. That's incidentally he comes to hospital with some other illness and you find aneurysm inside him. Or a grade 1 where the asymptomatic or minimal headache is there with normal neurological function. So the more the severity of neurological dysfunction, the more will be the grade. So the grade 4 is something like stupor, moderate to severe hemiparesis, and the grade 5 becomes deep coma, decerebrate rigidity, and moribund appearance. If you note right side of this column, the worse the grade, worse is going to be the outcome. So more mortality in the high grade patients. Also, when if any other severe systemic illnesses are there, like a COPD, uncontrolled hypertension, the patient moves into the next grade. For example, if patient has minimal headache with normal neurological examination, but with uncontrolled hypertension, he moves to grade 2, not in the grade 1. So one grade lower we have to consider. So the more the associated abnormalities, more is the poor grade, more is the risk of neurological dysfunction. So there is also one CT based system is there, classification depending on the amount of the blood in the cisterns. So interhemispheric cistern, uveal cisterns, or the basal cistern. If there is no subarachnoid hemorrhage is detected, it is considered as grade 1. In the 2, the vertical layer of the will be less than 1 mm thick. If it is more than 1 mm thick, it becomes the grade 3, and any intracerebral bleed or intraventricular hematoma becomes grade 4. So more the grade is, more is the increased risk of vasospasm. So you see 20%, then it becomes to 40%. The more is the intracerebral hemorrhage or the intraventricular hemorrhage, more is the risk of vasospasm in the pre, peri, and post-operative. All the perioperative period, there is always a constant risk of vasospasm. So what are its effect on central nervous system? Immediate when it ruptures, as I already told you, increases the ICP. It can cause hematoma or decrease in cerebral perfusion, ischemia, or infarction. It can develop a hydrocephalus, aqueductal, initially either acute or chronic. Both the type of hydrocephalus is possible. This hydrocephalus itself can lead to intracranial hypertension, and there can be impaired autoregulation, and the overall ischemia can be caused because of the vasospasm. So these are the effect of SAH, aneurysmal SAH, on the central nervous system. So once there is a injury to the posterior hypothalamus or the large amount of blood bleed, what happens? When it sudden rise in the ICP, it leads to the sympathetic surge. This sympathetic surge increases the afterload of the myocardium and increasing the direct myocardial toxicity, leading to subendocardial ischemia. This a variety of ECG changes like a T wave inversion or the ST elevation, ST depression. All these variety of ECG changes, what you can notice in a patient with subarachnoid hemorrhage. What are the ECG changes? Both rate and rhythm changes are seen in almost 100. That means all the patients you are likely 50 to 100 means every alternate patient or almost all patients you are likely to find a change in the ECG. It is usually noticed within the first 48 hours, and all, for example, T wave inversion, ST depression, appearance of U waves, prolonged PT interval, Q waves, all the waves can be seen. And Fisher gradient is thus, that means more severe is the SAH, more is the ECG change. So these are the changes which are directly related to the occurrence of the subarachnoid hemorrhage. As you can see in this picture, there is a T wave inversion which is attributable to the subarachnoid hemorrhage which has already caused. And these ECG changes may return in 10 days to 6 months, 6 weeks of time whenever it is possible. So what are the differential diagnosis? Whether these ECG changes which are happening, are they related only to the CNS insert, or there is indigenous myocardial dysfunction is also there which needs to be defined. So these changes, when we consider as a differential diagnosis, It can be related a benign change due to SH, or it can be a myocardial ischemia or infarction, or there can be electrolyte disturbance like potassium, calcium, or sodium, which can lead to these ECG changes, or SH-related hypothalamic injury can itself, which controls the heart, can itself lead to these ECG changes. So all these four things should be kept in mind and should be ruled out whenever there is a sufficient doubt that these ECG changes may not be benign related to the SAH. So whether the changes are whether neurogenic or cardiogenic, still 0.7% of the patient do sustain myocardial ischemia in the setting of subarachnoid hemorrhage. So when they sustain like this, reversible neurogenic cardiac dysfunction, troponin level will be much lower than the acute MI setting. So, but we need to weigh a risk-benefit ratio when we want to take up these patients for the surgery. So, risk of bleeding of the aneurysm and the death is much higher as compared to a risk of occurrence of an intraoperative myocardial infarction. So, these patients should be considered as an emergency for either clipping or coiling of the aneurysms. So, what are the effect on respiratory system? The itself does that it can lead to the pulmonary injury by way of pulmonary edema. That means the increase in the sympathetic surge pushes the blood from the systemic circulation to the pulmonary circulation, thus increasing the lung water, causing the pulmonary edema, what we commonly call it as a neurogenic pulmonary edema, or a myocardial dysfunction. What happens because of this? So left-sided failure leads to a right-sided failure. Left-sided failure can lead to an increase in the pulmonary water, or poor GCS can aspirate and lead to a consolidation of the lung, leading to a pneumonia. So all these things are possible in the patients with aneurysmal subarachnoid hemorrhage. What happens to autoregulation? So as long as the good grade patients are there, autoregulation and CO2 reactivity will be maintained. That means the patient is able to maintain his cerebral perfusion pressure at a higher and even at a lower pressure. But this impaired autoregulation is present in a poor grade patient and can, particularly in the presence of vasospasm, can lead to delayed ischemic neurological deficit. That means these poor grade of patients are not able to compensate for that autoregulation. If autoregulation is there, they should be able to maintain that. So they will not be able to maintain, thus leading to cerebral damage. Very similarly, CO2 reactivity is also well preserved in most of the patients except very poor grade patients where there is a severe damage. They will not be, CO2 reactivity will be lost. So CO2 reactivity and impaired regulations are present with good grade of aneurysm. What happens to the intravascular volume? So since the patients can have a poor GCS, so their intake reduces, so they can have a reduced intravascular volume. Almost nearly 80 to 100% of the patients of hemorrhage can have a reduced intravascular volume because of they are on bed rest, they have a poor GCS. It correlates with grade. That means poor GCS, poor intake, more is the depletion of intravascular volume. Also, supine position, constantly they are lying, leads to supine diuresis, reduced intake, and the iatrogenic blood loss, what happens in the intraoperative period, can also lead to the hypovolemia. So, this hypovolemia, why it is more important? This hypovolemia may exacerbate vasospasm and increase delayed ischemic neurological deficit. So, we need to avoid hypovolemia at any cost. Euvolemia is initial period is better to be maintained in this group of patients. So what is the hyponatremia? Hyponatremia is present in 10 to 40% of patients with subarachnoid hemorrhage. So because the intake will be less, any sodium concentration less than 120 should be considered as critical and it should be intervened. So most common causes of hyponatremia may be SIADH, that means syndrome of inappropriate secretion of antidiuretic hormone, which leads to hyperolemia or euvolemic hyponatremia, or there can be cerebral salt wasting syndrome, which can lead to hypovolemia. So the differentiating the two is very important, as this requires reduction of fluid, whereas this requires constant giving of the isotonic fluids, which is more important. So, uh, so the next, what to do early versus late. So when to take these patients, immediately or late? By convention, now the present modality of treatment goes they are clipped as early as possible. But previously, it was considered that more after 10 days of the occurrence of SAH, the risk of vasospasm reduces, hence they should be treated late. But the consensus is early versus late. But what the question, next question is whether to clip or coil, whether we should go for a clipping of the aneurysm or coiling of the aneurysm. So this was a study which compared clipping versus coiling in 2,143 patients in Europe. So this was published way back in 2005, and what it has said that endovascular coiling is more likely to result in independent survival at 1 year than non-neurosurgical clipping. The survival benefit continues for at least 7 years. That means clipping is always desirable than coiling in this group of patients. But most of the surgeons, they still feel clipping is one time the solution as it reduces the or in almost nullifies the incidence of rebleed or rupture rebleed or re-rupture, whereas the coilings can still have a rupture. So there is an ongoing debate still about clip advantages of coiling and clipping. It depends on the institutional protocol. In our institution, clipping is the most preferred method of treatment of these aneurysms. So what when to do early or late? When an early surgery is done, it is not emergent or emergent. It depends on the setup. But the disadvantage is you can have a angry or edematous vein because the SH has occurred recently. There can be a cerebral edema, and you may get an incidence of edematous brain more as compared to a late surgery. In the late surgery, brain conditions may be better. Risk of rebleeding is there when you delay the surgery for 7 to 10 days. And when the aneurysm rebleeds, then the first bleed, the mortality risk is much higher as compared to the first time bleed. So always now the preference is to go for the early surgery with tackling the edematous brain with various measures. What about the pre-medication to these patients when you want to take up them for surgery? So higher grade aneurysms, generally no sedatives or pre-medications are given. Even the good grade patient, they will be kept on sedatives to avoid the anxiolysis or increase blood pressure and all. So they will be on anxiolytic medications. Imodipine is given 60 milligrams 6 times a day for 21 days. That will be continued in the perioperative period. Anticonvulsants like phenytoin 100 milligram TDS are routinely prescribed. Also proton pump inhibitors, and if there will be severe back pain or any other pain, paracetamol or Opium can be used. So all these patients, once they present with aneurysmal subarachnoid hemorrhage, they are admitted in the neurointensive care unit and they are monitored under close supervision. So if you want to give pre-medication, it has to be on the close monitored site like a neurointensive care unit. A good grade aneurysm can be given sedation. But in patients with poor grade aneurysms who are already intubated in the ICU, while come to the OT operation theater for the surgery, always a drug should be given for avoid coughing or bucking of the respiratory tube because it itself can increase the blood pressure and risk of aneurysm rupture. So what are the pre-anesthetic considerations what we are going to have? Airway we need to be able to sure that what is whether it's a easy airway or a difficult airway. It has to be on the patient. Some in the poor grade patients you may not be able to evaluate the airway conditions. We should note the coexisting illness because they are going to decide what is the blood pressure we are going to keep and how we are going to manage. And complete blood count, renal parameter, coagulation, and electrolyte should be checked and treated before taking these patients and surgery. Echo and chest X-ray are done. So echo basically to know whether there is a cardiac depression or a cardiac dysfunction following aneurysmal subarachnoid hemorrhage. Always blood should be typed and screened and cross-matched and kept ready for aneurysm surgery. So what are the anesthetic goals? The most important anesthetic goals are to prevent aneurysm rupture. So avoid any hypertension at induction or intraoperative period. So hemodynamic management is the most important in this group of patients. If you reduce the blood pressure too much or the cerebral perfusion pressure is reduced less than 7, it can lead to ischemia. So prevention of ischemia. And since now we are going for early surgeries, providing a relaxed brain to the surgeon becomes very important. So we have to provide them ease of surgical exposure by providing the lax brain and also to prevent cerebral ischemia from retraction. So a lot of the time they will be retracting the frontal and temporal exposure of this basal arteries that can itself lead to retraction anemia and ischemia of that part of the brain. So for the reason this, we need to provide a relaxed brain to this. And following the surgery, as for any other neurosurgical patients, rapid and smooth emergence is important for neurological assessment. So these are broad anesthetic goals with which we are going to manage this group of patients. What about the hemodynamic management? As I told, it is very important. As we know the equation that cerebral pressure is equal to mean arterial pressure minus intracranial pressure. So anything, either gross increase in the intracranial pressure or a reduction in the mean arterial can reduce the cerebral perfusion pressure. So why is it most important? Because this determines the cerebral ischemia. So if there is a cerebral ischemia, even if you do a successful surgery, it is not going to be a good outcome surgery. So CPP management is most important. For that, minimum the blood pressure is more important. So hypotension and increase in ICP, such as following laryngoscopy and all, can compromise CPP. Hence, they should be avoided. So the basic rule is maintenance of the cerebral perfusion pressure. There is something called as transmural pressure. That if you note the equation, it is very similar to one which was given before. Transmural pressure is nothing but pressure across the vessel wall. So any sudden increase in the mean arterial pressure can positively increase the transmural pressure, hence facilitating the aneurysm rupture. Or any sudden decrease in the ICP can increase this equation positively, and again it can cause aneurysm rupture. So this transmural pressure is nothing but pressure across the wall, which determines the aneurysmal rupture. So what are the things which can increase the MEP abruptly, like intubation response, skull pin fixation, what you commonly see, or during the surgery, or inadequate depth and analgesia can all increase MAP suddenly, which facilitate the aneurysm rupture. Or when you are putting a lumbar drain or a aggressive hyperventilation, fast giving the loading the mannitol, or sudden opening of the dura can all reduce the intracranial pressure, thus increasing the pressure across the vessel wall, what we call it as a transmural, and can lead to aneurysm rupture. So what is we are supposed to do? There is a balancing act. I don't know how we will stand on this single leg like this. So it is the balancing act to prevent cerebral ischemia versus prevention of the rupture. So we need to do a balancing act. So how do we go about induction of anesthesia? So here we are doing the higher dose of fentanyl as compared to the routinely what we use to avoid or nullify the intubation response what you get. So a smooth induction to avoid a hypertensive response to laryngoscopy and intubation is most important. Though now with the modern agents and better understanding of the pathophysiology, the risk of aneurysm is very less during induction of anesthesia. We need to be careful while inducing these patients. A good dose of induction agent, analgesic, and a vecuronium, the patient will be ventilated for 3 minutes, and additional bolus dose of propofol or the induction agent thio, if you are using, you can give a additional 2 to 3 milligram per kg of thiopentone sodium, or a lignocaine can be used to avoid or nullify the effects of the stress response what laryngoscopy and intubation is providing. The same, these agents can be repeated during the skull fixation. A scalp block may be given to avoid the response of the patients for skull fixation, skull pin fixation. How do we maintain our these patients on anesthesia? So what to go for it, whether the inhalational or a TIVA. As of now, for a good grade patients where there are no features of raised intracranial pressure, both of these techniques can be safely used for the intraoperative management of the patients for maintenance of the anesthesia. Or we can use a combination of both for most effective brain relaxation of therapy. But for patients who are at high risk of raised intracranial pressure or a poor grade patients, the use of inhalational agent increase the cerebral blood flow, further aggravating the raised ICP and cerebral ischemia. Hence, TIVA can be preferred in these group of patients. But when we are using a TIVA with the dose and the maintenance, we should be very careful of hypotension being caused by the TIVA agents like propofol. So either of these can be used as a summarize. Summarize, either of the agents can be used for the maintenance of anesthesia. What about hyperventilation? We know we are using hyperventilation daily in the neurosurgical patients. What to use, whether to use them now. The hyperventilation classically reduces the pulmonary partial pressure of the carbon dioxide in the arteries, thus causing a cerebral vasoconstriction, which reduces the cerebral blood flow, and this reduction of cerebral blood flow reduces the ICP. In a good grade aneurysm, if we use when there is no raised ICP is there, and if we use a hyperventilation, there will be a sudden decrease in the intracranial pressure, which shifts the transmural pressure to a positive side. That means MAP minus ICP. If the ICP reduction is sudden, it can cause rupture. So, in a good grade aneurysm, hyperventilation should be avoided. Whereas in a poor grade aneurysm with a raised intracranial pressure, hyperventilation can be used for the reduction of intracranial pressure. So, good grade aneurysm, no hyperventilation. Poor grade aneurysm, hyperventilation can be used. What about the monitoring? The classical asked question is whether to secure the arterial line under local or under general anesthesia. So, if you are an expert in the arterial line, if you can get the radial artery or a dorsalis PD, you can secure the arterial line under local anesthesia. But my institutional practice and my protocol is I always secure the arterial line under general anesthesia after intubation of the patients, because most of the time in my institute postgraduates will be the one who will be securing the arterial lines. So I always prefer to put them. As the NIBP, we can measure every 1 minute the blood pressures. So we can use, but in patients who are at high risk like a cardiac morbidity and all, we can put the arterial line under local anesthesia. The other monitoring modalities which are used routinely is the insertion of the central venous catheter, monitoring of the CVP, and the end-tidal carbon dioxide concentration for manipulation of the hyperventilation and the intracranial pressures. So these are the monitors. So even in this patient, you can see the T-wave inversions in the patients. So what about mannitol and CSF drainage? Mannitol is still commonly used drug in a dose of 1 gram per kg for the brain relaxation in this group of patients. It works very well, and you can find a good brain relaxation scores with the use of the mannitol in you. Some surgeons prefer to do a CSF drainage for the better. So why is it so important suddenly the CSF drainage? Because we are going for the early surgeries nowadays, so we may find a tense brain, the angry brain more frequently as compared to before. So or we can have a raised ICP because we are doing the early surgery. So CSF drainage may work wonders as compared to the mannitol, because definitely it is going to reduce the intracranial pressure. But if you allow the sudden drainage of the central cerebrospinal fluid, it can again shift the transmural pressure. The equation same, TMP is equal to MAP minus ICP. So CSF drainage will suddenly going to reduce the ICP, which can lead positive TMP and cause aneurysm rupture. So it should be avoided. Whenever you are putting a CSF drainage, avoid rapid loss of CSF. Put a catheter and slowly you can open it for the CSF drainage. What about fluid management? The normovolemia should be maintained before the aneurysm is clipped. So balanced size solution are the commonly used. If you avoid hypovolemia, it can increase the risk of vasospasm and subsequent delayed ischemic neurological deficit. Hence, hypovolemia should be avoided in this group of patients. The blood products indications are the same, like hematocrit less than 30%, can do a blood transfusion. And once the aneurysm clipping is done, so to prophylactically to avoid the risk of vasospasm, we can start increasing the central venous pressure to around 10 to 14 centimeters of water. That means keep the tank full so that you avoid the risk of vasospasm. What are the intraoperative events? That is most important thing is the reduction of blood flow to the aneurysm. So as you reduce the blood flow, clipping becomes easier for the surgeon. So there are two techniques which are commonly practiced. One is induced hypotension and temporary clipping. This induced hypotension is nothing but the global reduction in the blood pressure. This reduction can cause the reduction in the cerebral blood pressure, hence putting the most of the part of the brain for the risk of ischemia. That is the reason this induced hypotension is not commonly used nowadays, whereas a temporary clipping is used where the feeding vessel which feeds the aneurysm, that means the blood from which vessel it is flowing to the aneurysm, a clip is placed temporarily on that, which causes only the regional ischemia of the brain but reduces the flow to the aneurysm, and thus causing the facilitating the clipping of the aneurysm. But since it is providing regional ischemia, we may increase the systemic blood pressure to improve collateral circulation, whatever present in the brain. To improve it, we can increase the systemic blood pressure. So this is one which is commonly used. So in this video, uh, 1 minute. So in this video, you can see a temporary clip being applied on a feeding vessel. If you can see, it's a temporary clip which is being applied, and then after a temporary clip is applied here, a permanent clip is applied to the aneurysm. So you can see the neck clearly in this video where the clip is being applied. So if you see both the videos, this clip is a gold in color, this clip is the aluminum in color. What is the difference between these two? So a temporary clip is different from a permanent clip. Both cannot be interchanged. Temporary clip has a lesser occlusion pressures. That means when you put it on the, it occludes the vessel, but it will not injure the vessel. Whereas the permanent clip has a higher occlusion pressures. It causes damage to the intima of the vessel, thus causing fibrosis and effective healing of the aneurysm. So a temporary clip and the permanent clip cannot be interchanged. Temporary clip is temporary clipping. Permanent clip damages the intima and closes the aneurysm permanently. So it has a higher occlusion pressure as compared to the lower occlusion pressure temporary clip. So what are the cerebral protection? So when you know that you are putting a temporary clip, there is a certain part of the brain which is under risk of ischemia. So we need to protect. So what are the most common modalities what used? So none I have written as a first most common. So if you are anticipating a lesser temporary clip time, so you need not use, like for example less than 5 minutes, 3 minutes, you need not use any cerebral protective agent. So the brain can tolerate that part of ischemia, and the inhalational agent what you are using can provide some part of ischemic preconditioning, and it can save the brain whatever is at risk. A mannitol additional dose can be given at this point of time before temporary clipping, because mannitol has additional effect like antioxidant effect, and this can lead to cerebral protection. Sendai cocktail, which is given in most of the books, can be used. It's from Japan, one of the papers which stated that with the use of these three agents, dexamethasone 50 milligram, vitamin E 500 milligram, and a mannitol 100 ml, you can extend the temporary clip time up to 40 minutes. But subsequently, none of the papers have validated this study, but still it is commonly posted. After the IA study, hypothermia is not routinely used for introduction of the hypothermia does not necessarily protect the brain. So hence it is not commonly used. However, if existing hypothermia is there, for example, a mild to moderate hypothermia of 34 to 35 degree following induction of anesthesia, we need not actively treat it. So you can just be a masterly inactivity till the aneurysm is clipped. Or in patients with high risk of cerebral ischemia, a burst suppression doses of propofol or thiazide can be used with monitoring of the burst suppression, either using a BIS or using a electroencephalography. Either of the monitors should be used for the burst suppression. So what are the specialized monitoring we use? EEG electrophysiology, because it can detect ischemia, and 50% decrease in amplitude corresponds to the regional blood flow less than 15 ml per 100 gram per minute. So this EEG is getting affected, so means it is better to provide the protection to the brain by any of these agents, reduces the cerebral metabolic rate of oxygen. So hence EEG can be used. So we studied thiopentone and propofol in brain protection during temporary clipping with having the control group. So we used a BIS monitor with burst suppression ratio of 80%. We gave these two drugs till we achieved a burst suppression of 80%. So it was a pilot study and a small study subsequently done by the other researchers also. We did not find any difference in the outcome. So in patients with a short duration of temporary clipping, give any drug or you may not find any difference with these two agents. Then we followed with one more study in our institute in Ames itself, where we used for the cognitive assessment of the cognitive dysfunction when we gave these drugs. So there was no difference in outcome. So if you are not anticipating a difficult clipping and if you are not anticipating there will be a prolonged clipping time, you need not give any of these drugs. However, additional dose of mannitol does no harm. You can give a mannitol before application of the temporary clip. What happens if intraoperatively aneurysm ruptures? If the intraoperative it's a acute emergency again, the rupture causes a torrential bleeding, and most commonly it happens during either dissection or clip application time. And the initial paper stated it is associated with higher mortality and morbidity. But nowadays, with the recent advances and the good microscope instruments, this is a questionable sentence. So hence, mortality and morbidity may not be affected if a rapid clipping of the aneurysm is attained. So how do we manage this? So initially, when the aneurysm bursts, we can give a bolus dose of thiopentone or propofol to reduce the global cerebral blood pressure, so that aneurysm can be seen easily, and we can put a temporary clip somewhere on the fluiding vessels. Then, whatever the blood or fluids are lost, we can restore the intravascular volume, and the rapid surgical control can be gained for blood loss. So these are the way how we are going to tackle intraoperative aneurysm rupture. In this video, you can see the dissection is going on. Just the suction itself dislodges that clot where the aneurysm has already ruptured, and you can see the torrential bleeding, how it is happening, which is very difficult to control. So this is the reason intraoperative aneurysm rupture is a devastating complication which needs to be tackled immediately. So how do we proceed once the clipping is done? Once it is done, we need to ensure that clip is properly in place and there is no neck remaining, so that there are risk of re-rupture are eliminated. We can visually inspect the aneurysm. You can rupture the aneurysm and see whether the clip is properly in place, or you can use an intraoperative Doppler for seeing the blood flow velocities in it. And also, in green, you can do a indocyanine in green video angiography using 0.2 to 0.3 milligram per kg of indocyanine injection, and see in the vasculature whether all the vessels are filling or not except the aneurysm. So once this is done and you are sure it is fine, you can start lightening the anesthetic depth a little bit. This is the systolic blood pressure, 20% of the baseline. The CVP can be increased now to avoid the hypovolemia and the subsequent risk of cerebral vasospasm. So in this video, you can very clearly see the indocyanine dry is given. The aneurysm is being isolated. It is placed at the neck, and all the vessels, feeders are very clearly seen. So this is the advantage of having the intraoperative indocyaninogram video angiography, where you can eliminate the any risk of rupture of the aneurysm by clipping it properly. So how do we plan the recovery from anesthesia? Generally, a good grade aneurysm, they do recover well, and if there are no intraoperative events, untoward events in the intraoperative period, they can be extubated on table in the OT. So there is no need for them to go for a mechanical ventilation. Grade 3 aneurysms are a bit dicey because they are drowsy when you are taking them in the preoperative period. And in the intraoperative period, based on the events, you can plan whether you want to extubate them, or if you have a dedicated neurointensive care unit under yourself, so you can just plan them to have a mechanical ventilation for a few hours, see their response, and you take out the tube. But definitely, grade 4 and grade 5, that's the poor grade aneurysms, they require a elective ventilation in neurointensive care unit and a intensive care management for better outcome. So you may not be able to extubate them immediately, but they may take a longer period of elective ventilation for the better outcomes in this group of patients. So how do we care during extubation? During extubation, Our coughing, straining, or agitation of the patient on the endotracheal tube should be avoided. This can increase the drastically blood pressure, and if aneurysm is not properly clipped, can cause the re-rupture of the aneurysm. So, hence excessive increases in the blood pressure should be treated. Adequate pain relief must be ensured because in most of the neurosurgical patients, because of the fear that we want them to be awake in the immediate post-operative period, lesser the analgesics are given. This can all contribute to increase in the blood pressure. So, adequate pain relief should be provided. And if new neurological deficits are there, which so we can look for any reversible causes like a neuromuscular blocker still acting or a sedative hypnotics. If none of all of these have been ruled out, then you can do a CT scan to check the placement of the clip or development of any ischemia or infarction in the brain. So there are some special situations which are most dangerous to manage, particularly for anesthesiologists. So approximately in 10 to 20% of the cases, there will be multiple aneurysms. So in a aneurysm, single aneurysm, what we learned of a hemodynamic management was post clipping, the increase the blood pressure 20% from the baseline, and also the increase the central venous pressure to 12 to 14 centimeters of water. But this is not always possible when the multiple aneurysms are there, because once you treat one aneurysm, the other aneurysm also may be at risk of rupture. So any increases in inadvertent increases in blood pressure can lead to rupture of that aneurysm. So in these group of patients, better the increase in the blood pressures may be avoided. And again, during extubation, care should be taken that you avoid coughing or bucking of the patient on the endotracheal tube. So there are some special situations where you need to use this special drug called adenosine. So because some of the difficult aneurysms like a basilar top aneurysm or a supraclinoid or clinoidal IC aneurysms, which are very difficult to treat, so you may want an extra bit amount of time for the dissection and the proper clipping of aneurysms. Once a normal blood flow and a blood pressure or a cerebral blood flow is there, it may be difficult to find the aneurysm, but aneurysm or leg, particularly when a big aneurysms are there. In these cases, adenosine dose of 0.3 to 0.4 milligram per kg bolus can be given, which causes a severe bradycardia and hypotension. This bradycardia of when you give a bolus and a maintenance dose may be around less than 30 heart rate per minute with a BP of around less than 50 millimeters of mercury. When this much amount of severe hypertension and bradycardia is there, surgeon can immediately see the neck dissect better, faster, and it will facilitate the clipping. But when you use these drugs, it can cause a cardiac arrest. So our pacing, percutaneous pacing ready and already attached to the patient in case arrest happens and the revival is not faster. That means the generally stop adenosine, the heart rate comes back in 9 to 10 seconds to a normal. So if it is not there, so you should be able to use a percutaneous pacers for the management of the heart rate. So this itself can lead to bronchospasm and increase the airway pressure, which can further aggravate a cerebral edema cerebral edema, so or raised ICP, which we should be careful. And in patients with myocardial ischemia, in patients with coronary artery disease, this can precipitate a myocardial infarction. So these are this group of patients you should take extra care when you are using drugs like adenosine. There are some situations like pregnancy where the patient is pregnant and she has got aneurysm also. All the way we learned that aneurysm and emergency immediately should be cleared. If it is a first trimester or a second trimester of pregnancy, the answer is easier. You just go for clipping of the aneurysm with continuing the pregnancy with monitoring. But if it is in the final trimester, like a full term pregnancy is there, it is very difficult to say when to operate, what to operate first, whether to aneurysm or do a section following aneurysm or aneurysm clipping following that a cesarean section. So there are several, and since the patient is already supposed to be full stomach pregnant patient, so whether we should go for a rapid sequence induction. So once you any opioids for a rapid sequence induction, then the increase in blood pressure following the laryngoscopy and intubation can itself cause a rupture of the aneurysm. So we need to go for a modified rapid sequence induction in this group of patients. Also, we need to have an obstetric and fetal team as a standby for monitoring these patients, because these are the teams we need to have a standby, because any untoward incident happens, immediate cesarean section can be done, and the obstetrician should be informed that already a opioid has been given, and the patient may, the baby which is born out of cesarean section may be at a risk of respiratory depression. Hence, naloxone may be required in these babies. So there are some situations where the special situations where difficult airways are there. So what to do when a difficult airway along with the aneurysm is there? Whether to go for awake intubation or whether to go for a intubation under anesthesia. So if you are sure of mask ventilation, then you can go for a intubation under anesthesia. Awake intubation itself has its own risk, like when you give a nerve blocks, patient can cough, or your success of your awake fiber optic intubation depends on your skill and expertise. But with the since new advent of the video laryngoscopes, and since everybody now has got used to the video laryngoscope, intubation under anesthesia can be safely performed in these difficult airway patients with a aneurysm or a intracerebral aneurysm. So this must be easier now as compared to before. So there are some special situations like a big basilar top aneurysms are there, or a big supraclinoid aneurysm is there, which cannot be kept. They are very complex, and rupture of this, there is no access to control the blood bleeding. So in this group of patients, we can go something for a deep hypothermic cardiac arrest. Either a femoral bypass or a sternotomy can be done, and getting ready, keeping everything ready for a aortic and a right atrial cannulation if in case any untoward incident happens, or if you want to electively go for a bypass, so you can bypass the heart, arrest the circulation, and then subsequently you can keep the aneurysm. During these scenarios, it is always better to monitor electroencephalography for detection of any cerebral ischemia. So in and all, the improved outcome depends on the anesthetist who is familiar to all the overall homeostasis, maintains adequate cerebral perfusion pressure, and attenuates and treats all the risk factors which can cause the poor outcome, like increase in intracranial pressure, a brain swelling, or a vasospasm, or and also a surgeon who is skilled enough who dissect the aneurysms and clips without doing much of the trauma and faster as much as he can possible. So these are the things which determine improved outcome in patients with cerebral aneurysms. Thank you for your patience and kind attention. Thank you. Over to Punaya now.
Thank you, Dr. Prasanna. Thank you for the presentation. Dr. Prasanna,
Yeah.
I have a few questions for you.
Yeah, please.
Regarding the use of anticonvulsants.
Yeah.
There's some noise from your end, yeah.
No,
Regarding the use of anticonvulsants in subarachnoid hemorrhage.
Yeah.
What is your practice? Because the guideline says that if there is no seizure, there's no need for anti-epileptic drugs. Do you use routinely phenytoin, or if at all you want to levetiracetam, that is a guideline. So what is your practice in your institute?
Yeah, we do routinely give anticonvulsants to all patients.
Okay.
Initially, we were using phenytoin 100 milligram PDS.
Okay.
Now we have switched over to levetiracetam for all the patients.
Okay, let me bring in Virender here, Dr. Virender. Dr. Virender, what is the practice in your institute regarding anticonvulsants in subarachnoid hemorrhage patients?
Generally, we give anticonvulsants, and if the patient does not have any seizure also, we generally give that. So it's because to improve the function, if the patient does well, then we continue after 1 to 3 months, depending on the clinical status.
Okay. Dr. Manish, you have anything to add in this?
No, same thing.
You do routinely give anticonvulsants?
Yes.
Okay. And Prasanna, the second question is regarding the use of adenosine.
Yeah.
We all know that we can use adenosine. Adenosine can bring a transient cardiac standstill so that the aneurysm lags and they can.
Yeah.
Can you tell specifically to the trainees exactly at what point we should give the aneurysm in case of an unruptured scenario and in case of a ruptured scenario?
Uh, so it is actually in a ruptured scenario. I have never used it. I
Okay,
use better use a uh, anesthetic agent which causes the reduction of cerebral metabolic rate of oxygen also, like a
okay,
propofol, which causes a reduction in the BP acutely around 60 millimeters to 70 millimeters of mercury of
okay,
systolic. That is enough for me.
okay.
But in a difficult aneurysms, yes, we have used adenosine,
Mm.
and we have used adenosine many times for supraventricular tachycardias, and we know the safety of the drug. So the
Yes,
moment you stop it, heart comes back to normal. So
correct.
what we need not achieve a full cardiac arrest using adenosine. Even if you are able to get a heart rate of less than 30, 35, the surgeons since overall BP is reduced, the flow becomes the aneurysm becomes lax. So they have space to dissect.
Okay.
So and it does not mean that eternally we can be giving the adenosine for all the patients. So we need to time it so that when most of the superficial dissection is over and the surrounding tissue is over and he is approaching near the aneurysm and he wants to locate the neck now very clearly, that is the time when we can give.
Okay. Dr. Virender, do you have any experience of
Yeah.
giving adenosine in a ruptured scenario?
No, no, no. I don't have any experience right now. I think Dr. Hemant in PGI, he has some experience, but he's right now not with in this group, so I don't know. But he has some experience with around, I think, 20, 30 cases.
Okay. All
I
right.
can I add something?
Yeah, yeah, Dr. Manish, go ahead.
Okay, I have tried adenosine a few times, but the problem is that so many times it is very difficult to get the cardiac stent still. And the other thing that even the hypotension is very transient. So rather than the safety, the main problem for me was efficiency or efficacy.
So you mean to say it lasts only for a few seconds and
Yeah, yeah,
within
less than
injection?
1 minute. Yeah, most of the times it was
Yeah,
less than
yeah.
1 minute.
So maybe like Dr. Prasanna said, maybe in an unruptured case at a difficult location aneurysm where the
No,
it's
Dr. Punaya, can I make a
yeah,
point?
yeah,
Yeah,
please.
we need to give around 40 to 50 milligram of adenosine. Generally, what we give adenosine is around
Right.
6 milligram or 12 milligram for a supraventricular tachycardia, right? So
Yes.
here what we have to do is we have to go for a higher dose around 20 to 30 milligram bolus for the first time and a rapid bolus. That is what we generally tend to forget. Rapid bolus will achieve rapid.
Hmm.
And sustaining it, as Dr. Manish told, it is always difficult.
Yeah.
So in the important stages, it can be used very effectively.
Okay. And one more question for you, Dr. Prasanna, regarding the emphasis on CVP and
Yeah,
hypervolemia.
yeah,
What is the take? What is the current take on that? Because nowadays we focus more on hypertension rather than
yeah.
hyperolemia and filling up the patient, maintaining normolemia and maintaining higher
Hmm.
blood pressure. So, what is your take on that? You
Uh,
still follow hyperolemia and loading the patient with a lot of fluids and colloids?
no, in a patient who is on a controlled ventilation in the intraoperative period, 10 to 12
Okay.
centimeters of water of CVP is not hyperolemia. That is first.
Hmm.
And if you take heart as a horse, okay, fine. So if you take heart as a horse and if you whip the horse with only hypertension, you want to bring the hypertension using phenylephrine or some vasopressor. Without providing food to the horse, it cannot run. So we need to have the tank full, we need to have the horse stomach full, then only it can effectively contract.
So, what is
So,
your policy on that? Use much of crystalloids only or use colloid as well?
colloid we are totally stopped. Only crystalloids we use. So
Only
colloids, since particularly the more and more papers coming with the atastage increasing the renal failure. So we almost totally stopped using colloids in neurosurgical patients. It's always the crystalloids what we used or a plasma light, whichever is available.
And what about how about the diuresis? When you use a lot of fluids and hypertension, you get a lot of diuresis. How do you manage that?
Uh, Generally, it's not an issue. I don't. A lot of fluids
Yeah.
always use diuresis is not true because you have used mannitol. A lot of the agents you have used. So try to maintain the CVP. In a few patients where I found it's very difficult to control the diuresis, I used even the desmopressin nasal sprays of 10 to 20 mics for each spray, around 2 to 3 sprays through the nose for reduction of the urine output.
Okay. This question to you, Dr. Virender. In the post-operative period, to
Yeah.
manage the diuresis when we use hypertensive, hypervolemic therapy, do you use agents such as fluorocortisone and things like that?
We have used sometimes, not regularly.
Okay.
Sometimes we have used because same problem. If you have a extremely high urine output, then to control the intravascular volume, sometimes we have used these things, but not regularly.
Okay. And one more question regarding this hypothermia. This IHAST trial, they've used the hypothermia only in a low-grade aneurysm. So what about in high-grade aneurysm? Are there any guidelines to manage such neuroprotective agents, or it's just a evidence-based? Is there an evidence-based practice for that?
Right now, I don't think hypothermia, nobody is practicing full in complex scenarios and very tense brains and all those things. It is not, it just adds to your anesthetic practice by decreasing the cerebral metabolic rate and all those things. But I don't think now we are in that era that we are using regularly the hypothermia.
Yeah.
Yeah.
Okay. And there are some questions from uh, our viewers.
Yes.
Question from Dr. Anil Parag is: can grade 1-2 patient can be done under supraglottic device? It will provide hemodynamic stability, less relaxant, and OPIs. The experts can answer. Dr. Virender first.
Yeah. I think we have good experience regarding that. In good grade aneurysms for aneurysm coiling, you can use ProSeal devices, provided that your access and your airway protection is good and all those things, and less hemodynamics. The only thing is when you need to convert, then that conversion to endotracheal intubation, suppose the intracranial bleed happens or sort of thing, that anticipation and close monitoring should be should be quick.
Okay. And
Uh,
other experts, you have any opinion on that, Prasanna?
Yeah, I think it can be used provided you have an extremely good fast surgeon who can finish the surgery in 2 to 3 hours. So if you have a difficult aneurysm which you are sure that it is going to go for 4 to 6 hours and you are anticipating any untoward incidents can happen in the intraoperative period, always better to go for endotracheal intubation.
So you would not recommend it for a low volume setup.
No, we have sufficient experience with the supraglottic devices in all the other conditions, but not in the neurosurgical patient still.
Okay.
So
So it
people
will
have used it in the even in the prone position for spine surgeries, everything. Still, papers are there. They are not into routine practice. So you need to be skeptical about using these devices in the aneurysm.
okay. Dr. Manish, you have anything to add
I
on
think
this?
Yes, I think that the problem is that with the rotation of head on so many times, the changed position which is required during the surgery, the supraglottic device may start causing leak, and if it happens during the surgery, because many a times we have seen even in like the patients who are undergoing chronic SDH under general anesthesia and with LMA, so many times the LMA causes the leak, and then we are in with difficulty. Suppose this happens in a aneurysm surgery, and if the aneurysm ruptures, then we may go nowhere. The
I
other
think
thing which I want to discuss is CVP, because although Prasanna is pro CVP, I will say that CVP in a normal range does not indicate does not indicate the volume status of the patient. Only when it is low or it is high, it reflects the volume status. So over
So
a wide
you
range,
don't chase a CVP in the
yes,
management.
yes, and sometimes it is very difficult to chase the CVP, and in the like while chasing the CVP, we can overload the patient and cause other systemic problems.
Okay. And my next question to the panel is about the specialized monitor. What situation you use the monitors like EEG, SGVO2, and TCDs, intraoperative TCDs? In what situation you use specialized monitors? Do you use it routinely for all the cases, or you select a case where you want to use a SGVO2 or a EEG, things like that? But the Manish, please first.
No, we have not used SJVU2 yet. in aneurysm patients, so that I'm not aware. Although it looks lucrative, especially in post-operative period where we intraoperative period is not of that much significance, but post-operatively it may be useful, but
Okay,
still
I'll
the
quickly
evidence
go
is
quickly
lacking.
to Dr. Prasanna. Dr. Prasanna, your views on that, please. Yeah.
Yeah, this SJ we were to, I think it's an indicator of a global cerebral oxygenation. So most of the time, particularly in the intraoperative period, what you are putting is a temporary clipping now, rather than using a global reduction in the blood pressure. So I don't think by any way it is going to reflect the oxygenation of that particular part of the brain which is at risk. Yes, in the post-operative period also, most of the time the area at risk is the regional area, like the lobe in a ACOM aneurysm or a temporal lobe in the MC aneurysm, which may not be directly reflected in the jugular oximetry. So I don't know whether it is going to be so helpful
Okay. How
in
about
the,
EEG? You mentioned about EEG in your presentation.
yeah. EEG you can use, particularly transcortical electrocorticography also you can use when you are contemplating that the aneurysm temporary clipping time is going to be prolonged. So EEG can be
So
useful
when
for surety that you attain the maximal burst suppression so that the brain is protected with
So
these
in a
agents.
difficult aneurysm where we want to use a
Yeah.
temporary clipping for a prolonged
Yeah.
period because
Ye-
nobody knows now what time is safer.
Yes.
So
Yes.
in that scenario, you'd like to use an EEG
Yes.
and neuroprotection.
Yes. Yes.
Okay, there are a lot
Yes.
of questions coming from our viewers. The next question to the panel is from a student. Sir, as DSA is the gold standard, when we take up the patient for the do we have to secure the airway electively, or does it purely depends upon the GCS status of the particular patient? And Dr. Prasanna, please.
Yeah, we need not secure the airway electively in all the patients who are undergoing distal subtraction angiography. In a patients who are good grade cooperative GCS, good GCS, we can do the distal subtraction angiography under
Okay,
local
but here
anesthesia.
comes an intermediate scenario where a
Uh,
patient is not either so poor grade or a good grade, but they'll be a bit restless. You not get a good image quality. Whenever you
uh,
don't get a good image quality, you are likely to miss an aneurysm. In that scenario, if at all you secure the airway, will you extubate the patient or keep the patient intubated?
so it depends on the finding on what you get in a DSA. If there is a clear-cut aneurysm, do a 3D angiography and you find aneurysm and you develop that scan and you see that it is aneurysm is surgically clip, you can put the clips. So better to ventilate and take the patient on the next day.
So it's on a case-to-case basis that you have
Yeah,
to make a
yeah,
decision on
yeah,
this. Yeah.
yeah.
Okay. So one more question from Dr. Srilata Mongi is
Oh.
recent literature speaks about 2H therapy rather than 3H therapy. What is your stand on that? And I think we have discussed this before.
Yeah.
Dr. Virender, you would like to shed more info on this
No, no.
about 2H rather than
Yeah,
a triple H therapy.
I think now the maybe in the future it will be only be a single edge. So the
Okay.
thing is, 2H is right now it's okay, and I think Prasanna has covered this topic elaborately. So the hypertension is a good thing, and along with the hypervolemia or euvolemia, whatever the clinical status of the patient demands.
Okay.
So
And
this,
one,
can I
yes,
make a
Dr.
point?
Prasanna. Yeah.
Yeah, this 2H or 3H therapy, whatever we say, is prophylactically it is not indicated. That means you just do not assume that
Ah,
it may develop a aneurysm, it may develop a vasospasm and start it. Supposing you find a vasospasm, supposing you find there is a neurological deficits are happening, like a decrease in the mentation of the patient. There is patient is slowly going down.
No,
You can
sorry to
always,
interrupt you. Sorry to interrupt you. You wait for the clinical neurological deterioration or by means of TCD if the velocities are high. At that
yeah.
time, you would like to initiate. Yeah.
Uh,
Before the clinical, at the time of clinical deterioration, already you may be going in for an infarct or a severe
no,
ischemia.
yeah, I'm not sure. Maybe Dr. Virender can answer this.
Dr.
I
Virender,
think
please.
you should have your patient should be euvolemic, not target hypervolemia for all your patients. It's only when you do a serial TCD examinations. So after that, yeah, when you see some and along with the induced hypotension, if you are seeing these things, then you can target these patients. So only after the clinical deterioration, then you do some other methods like transluminal DSA and intervention procedures like this thing, intra-arterial drug dilatation and all those things that can
Okay.
help your patients.
Sorry to interrupt, Dr. Virendra. Two questions for you. One is that a patient you clip the aneurysm, you don't find any clinical or TCT evidence of vasospasm. This is one clinical scenario. In which case, whether you would like to use prophylactic triple H or double H therapy or not.
No, I don't. I won't use that. I will keep my patients euvolemic, and I will just do a serial TCD and wait how the things start.
So we all know that we should avoid hypotension at any cost. But what level of blood pressure should be maintained? Is there a specific target level like 150 or 130, or we can accept even 110 in a patient who doesn't show any clinical signs or a TCD signs of cerebral vasospasm after clipping?
So it depends on the preoperative. If we know the preoperative clinical status of the patient, how his blood pressure controls have been, so we can accordingly decide what to do. So if we don't know the blood pressure status preoperatively, then we can simultaneously we can accept for a younger patients with no history of hypertension. Then we can easily accept 130, 150, 150 systolic blood pressures, or mean whatever targets you try.
The message is whatever may be the thing, we'd like to maintain a blood pressure at a slightly higher level, not aiming for severe hypertension.
No, not.
And one more question from Dr. Steve. One more question from Dr. Sridhar is that how about inducing severe hypertension to a range of systolic blood pressure 180 to attenuate the cerebral vasospasm? What's your take on that? What if you aim for hypertensive therapy? What should be the target for your hypertension? Till what level you will?
We have done twice or thrice to break that cycle of vicious cycle of vasospasm in a patient. We had once a time we had even taken the patient to a systolic blood pressure of 230, but not a regular. It should not be done, and it should only be 180 should be the target at which the severe hypertension you should aim at.
Okay. So what is your preferred agent for that?
Generally, in the normal clinical settings, we are using noradrenaline infusion. With dopamine, you have that difficulty that tachycardia also simultaneously happens. So we generally prefer noradrenaline to induce a hypertension in these patients. Yeah.
Manish, what is your view on this
scenario? See, we should also think of autoregulation. Suppose you are increasing the hypertension above the autoregulation limit, we should also always take care that there will be simultaneous increase in ICP, and that will decrease the CPP at the same time. At the same time, there are so many adverse systemic effects of induced hypertension that we should also take care. We are also injuring the myocardium, we are also injuring the kidneys, so that we need to balance these two pros and cons. So what we do, we unfortunately so many times the surgeons insist that the hypertension blood pressure has to be high to improve the perfusion, but it may not work all the time. So that it again depends upon case to case.
Okay. And one more question regarding the same topic is there a different BP target for patients who has suffered intraoperative aneurysmal rupture versus there was no intraoperative rupture? Are there different BP targets you would like to maintain?
There should not be. See, double S therapy or triple S therapy or S therapy, hypertension, they all are treatment. They are not vaccines. So that you should not give them until unless there is some evidence of vasospasm. So once there is vasospasm, you need to increase the blood pressure. Or sometimes the surgeon may see the vessels themselves and can say that yes, there is presence of vasospasm. That can be some intraoperative finding as well.
So it is the presence of vasospasm which dictates the hypertensive therapy rather than whether the aneurysm ruptures intraoperatively or not. Thanks, Dr. Manish. And now one more question about the TCD. I think we already discussed. There is a question about TCD. And one more question, Prasanna, for you. Viewer has asked: is there a drug other than nimodipine to prevent vasospasm? Are there any role of free radical scavengers to prevent vasospasm?
Yeah, that is a very good question. A lot of drugs have been tried which can replace a nimodipine. But as of now, even the clazosentan came with so much promise. Endothelin 1 A receptor antagonist. It came with so much belief that it will replace the nimodipine. So the role of nimodipine itself is questionable, except that one big study, nimodip trial, where they found marginal improvement of the patients. That is also the use of nimodipine is not found to reduce the incidence of any DIND or risk of vasospasm. It is only related to the good outcome, that is reduction in the mortality, absolutely by some 3%, I think. So, but after that, there are doubts whether this nimodipine actually does that. So, alternatively, several drugs have been tried, including magnesium, but clazosentan is the one which came with so much belief that, but it could not make a difference. So as of now, nimodipine stands the test of the day, and it is continued to be used as and that too in only the oral form through the right stream.
Okay, Prasanna, there are no more questions from the viewers. Right now, what we will do is we'll quickly go through a case scenario and get your opinion. And later on, I'll open the link for the viewers to ask their questions. They can join our Hangout and they can
Yeah,
interact quickly. Okay, shall we go to the
sure.
presentation? Yeah, let me go to the
Yeah,
presentation.
yeah.
Hope you can see my slides now.
Sure, sure. Yeah, Kunal.
Yeah, okay. So this is an interesting case scenario. There's a very young lady of 26-year-old. She has no comorbidities at all. But on one fine day, suddenly she had a severe headache followed by loss of consciousness. The relatives brought her to the emergency room. On the emergency room on assessment, she was still unconscious. There was some noisy breathing. However, airway could be maintained with the oral airway devices. And the SpO2 was 80% at room air, and with supplemental oxygen, it increased to 92%. She was slightly tachypneic to the respiratory rate of 24 per minute, and her heart rate was 88, and she had hypotension, 80 by 50 blood pressure. Her GCS was E3V3M5, GCS 11 by 15. Her pupils were equal and reacting to light, and she was moving all the limbs to pain. Her temperature was normal, and with supplemental oxygen, she was shifted for a CT shoot, and the plain CT revealed a diffuse subarachnoid hemorrhage grade 4. And immediately in the same setting, CT contrast was done, the CT angio was done, which revealed a supraclinoid ICA aneurysm. However, her breathing deteriorated, her ABG worsened, so she was intubated. Her lactate was 2.7 on admission, and her hypotension, some fluid challenge. In spite of that, hypotension persisted, so she was started on noradrenaline. However, before starting noradrenaline and other things, we did a chest X-ray. The chest X-ray after intubation, this is a chest X-ray of serial chest X-ray after intubation. It looks flooded like a pulmonary edema. And her echo showed severe LV dysfunction with ejection fraction of 29%. There was regional wall motion abnormalities everywhere except the apical segments, and her cardiac enzymes were normal. And she was started on noradrenaline, and this is the monitor screen, which looks perfectly okay. Her heart rate of 72, saturation of 100, with however with the FiO2 of about 60% and the PEEP of 8, and her BP was mean BP of 83, and normal central venous pressure and temperature. But what happened next was there was a decrease in urine output. Her lactate were climbing up, and she came in the evening, and the surgeon posted the case the next day first on the list. So how to go about this case, Dr. Prasanna?
Yeah, this is a classical case of a poor grade subarachnoid aneurysm with the sequelae following that. So I feel the patient is unconscious and the BP is low. So I find no reason to shift that patient on mask ventilation to the radiology suite to do the. So I will intubate the patient straight away there itself. And if ultrasound is there, definitely look for the, if she is requiring higher than the FiO2 what is required, to look for the presence of lines and whether there is a neurogenic pulmonary edema. Definitely I would like to have a positive pressure ventilation. Definitely it has some role.
Now the patient is intubated. She is on a noradrenaline infusion. Her monitor, I saw the monitor screen, it's perfectly looking okay. But her urine output is coming down, lactates are climbing up. she is posted for a surgery in the next day. So how would you like to proceed? Whether you want to optimize the patient further, or you like to proceed with the surgery because she is maintaining a good blood pressure with the noradrenaline?
The pressure must be okay, but the increasing lactate level sounds to me the alarming sign. So I would definitely like to put here a cardiac output monitor, see her SVR,
Okay.
and
Okay.
optimize her cardiac index, and see
Okay.
the SVV, all the other parameters. Look, and also see why the urine output is reducing. Maybe if the tank, and also see the volume status, because this is a classical case. If you do not give a fluid and we give noradrenaline, we may get the BP, because you see 20 ml per hour noradrenaline. I think it's much higher than what it is generally what we use, right? So I don't know the concentration of the adrenaline being used there, but 20 ml per hour is a very
No,
high
it isn't.
percentage.
It's a 20 mics per minute.
Huh?
It's 20 mics per minute of noradrenaline.
Yeah, I feel it is higher, so it can cause renal shutdown. So first you put a cardiac output monitor, optimize her using the see the cardiac index, SVR, everything. And also I would like to see an ultrasound is her particularly the cardiac status, and the cardiac status is actually down. So optimize it and then to decide on the next day morning whether to take up or not.
Okay, Dr. Virendra, you have a point here?
I think the cardiac output monitor will be of very good help in this case, and so to optimize the cardiac parameters. And I think if it is an emergency and the oxygen parameters along with the intra-op fluid management is okay, pre-op fluid management is okay, then we can take up the case for sure.
Okay. And Dr. Manish, what is your experience on this cardiac output monitoring? You like to go to cardiac output monitoring?
Before going for cardiac output monitoring, there is a simple thing which we can do to know the preload. We can, because the patient is on ventilator, on mechanical ventilator, we can simply do IVC diameter, measure IVC diameter on
The
ultrasound.
IVC was dilated in this case actually.
Because
When
already
did the
the
air question? Yeah.
Yes, so that if and variability with respiration, how much is there.
Yeah.
So if the patient is hypovolemic, then giving IV fluid, if that resolves the issue, if that improves the cardiac output, then it is good. But if it fails to, or the IVC is already dilated and we don't gather much information regarding that, then we can go for cardiac output monitoring. But two things are there. One, we've done that we may already give the optimal IV fluids and the patient might be euvolemic. And then if even higher doses of norepinephrine is required, then we need to uh, optimize the patient first rather than taking
So
the patient to
what
the
all the
surgery.
panel and everybody believes is that we have to institute an additional monitor apart from the routine monitors when in spite of maintaining a good blood pressure, the perfusion goes down. Form of lactate going up and urine output coming down. So that's where we have to think of additional monitoring like a continuous cardiac output monitoring or a non-invasive monitoring to assess the volume status and contractility of the heart. So one point well taken. That's a very good information. One more point, whenever they see a patient like this with a subarachnoid hemorrhage with no previous comorbidities but severe LV dysfunction and a patient has got a lot of regional abnormalities, do you routinely do cardiac enzymes? Is there any role for doing a cardiac enzymes, or we may not do any other investigations apart from this? Because stress cardiomyopathy is a known factor.
Yeah.
Dr.
No, no,
Manish.
it's basically that you
Maybe
have
Dr.
to
Virendra
rule
is
out
here. Yeah.
yeah. It's basically just to rule out the cardiogenic versus the neurogenic causes of the stunt myocardium that we are subjecting these patients to investigation. Like in where these facilities are not available, we
Okay.
can
I have
if
Dr.
the
Anil Parak
facilities
with
are
us. I have Dr. Anil Parak with us. Okay, let me go to him. Dr. Anil, sir, can you hear me? Dr. Anil, can you hear me? Sir, can you hear me? Okay, we'll get back to him later. You carry on, Dr. Virendra. Yeah.
yeah. So if the facilities are available and we have all the modalities that can be done, investigative modalities that can be done in the whatever time frame we have, then we can institute all these modalities. If we don't have these facilities, then depending on the urgency of the surgery and the urgency of the intervention, we can subject these patients to the surgery. So depending on the clinical status of the patient, all these things will be decided. Rather than getting the cardiac output from somewhere else, if you have the cardiac output, you can institute this modality. If you don't have, then you can use your clinical judgment to take up the case as well.
Okay. Okay. So additional, you mean to say the additional monitoring will be helpful in all case scenarios based on case to case basis. Then we have to utilize these monitors in improving the outcome of these kind of patients. Okay.
Yeah, can I make
Dr. Prasanna, please come right.
Yeah. In the scenario of a reduced or almost anuric patient, when there is a urine output is reduced, definitely I would like to follow the urea and creatinine values, because if the urine is not coming, how am I going to give the fluids in the intraoperative period? Because already patient has developed a neurogenic pulmonary edema. Already, again, she's
so you mean to say an additional, although the evidences are lacking, an additional monitor is definitely going to be helpful in managing the clinical status of this patient. Okay, got your point. Now coming to the same case scenario, when do you want to with the surgeon has posted for a clipping based on the surgical anatomy of the thing? Do you think that in specific scenarios where there is equivocal results for clipping and coiling, going for coiling will give a better outcome than clipping, considering the comorbidities of the patient? Dr. Prasanna.
Yeah, definitely coiling is better in this group of patients.
Dr. Manish, do you agree with that?
Yeah.
I'm not very sure about that, because see, there is no emergency to take the patient directly to the OT even before optimizing.
No,
the
that's
reason
fine.
is that
That's fine. In a given clinical scenario like this, whether coiling or craniotomy clipping, does it make any difference to the anesthetic management or the anesthetic management related patient outcome in this kind of patient?
see, in a lighter note, it is better, because coiling is better, because the person who is doing coiling will not say that the brain is herniating. But on the other side, if you compare both of them, so intra-arterial fluid infusion will be there in coiling. So we have to take care, as per
They'll also give a lot of fluids. Yeah, arterial fluids will be given. Yeah.
Lots of
Contrast
will also.
contrast nephropathy and all those things will be there. So yes, this both of these things would be difficult in such a case, and both will present different problems and different challenges to us.
So I'm not getting anybody online. Dr. Anil Parag came and maybe he didn't switch off the video, I think so. He left off. And one more thing I want to ask in this case is, during the surgery, to provide the lax brain, now what will be the measures we can use? Because the rejection is low, mannitol can protect the heart. Prasanna, can you put your views on this?
Yeah, can you repeat the question, Punay? There is a lot of disturbance.
Yeah, I don't know from which mic the disturbance is from.
Yeah.
In this scenario, for intraoperative brain relaxation, what are the measures you can utilize?
Yeah.
Because giving mannitol is going to be difficult, giving a 3% saline bolus is going to be difficult.
Yeah. Yeah, definitely. First and foremost is the positioning of the patient. Okay, I would be very careful when positioning this patient. I will definitely avoid any jugular compression, though they are routinely done in all the other surgeries and all the aneurysms. But I would be extra careful particularly in this patient, and providing the propped up position like a beach chair position, and also definitely I will ask the surgeon to consider the introduction of a CSF drainage, like a lumbar intrathecal catheter for the drainage of the CSF in the intraoperative.
Or a direct EVD.
Either in the form of EVD or a lumbar intraperitoneal catheter for the CSF, intrathecal catheter for the CSF drainage. Either of the one, definitely I'll ask him to consider it and go ahead with it, because mannitol or hypertension is not that easy.
Okay. Now, how about providing anesthesia? What is the agent what technique you use in these kind of patients with reduced cardiac reserve and pulmonary edema?
Yeah, I'll be very skeptical in using propofol. Definitely, I'll go for inhalational agents, inhalational based anesthesia, because I can actually use the agents much better, titrate them much better to the blood pressure, as since the patient is already on noradrenaline. So definitely I'll be worried to give propofol to this patients. I'll go for a inhalational based induction, see the intraoperative. When a burr hole is made, sees the brain condition. Too tight, definitely I'll withdraw the CSF some more. I prefer that than to give propofol and to land up in trouble.
Dr. Virender, your opinion on this? What kind of anesthetic technique would you use in these kind of patients, balancing the heart versus the
I
brain?
think I think Prasanna has already answered this thing. I think inhalational anesthesia will be better than the TIVA anesthesia. I am seeing a question on the Snap WhatsApp group regarding the lots TCD velocity is higher and I think Lindegaard ratio is the only differentiating factor right now. I'm not sure who has posted. I think some
Yeah, Dr.
Dr.
Prakhar has
Prakhar has
posted.
posted
Yeah,
it.
yeah, yeah.
Posted. So I think Lindegaard ratio should be the benchmark which we can differentiate global hyperemia from the cerebral vasospasm. The other thing which we can use apart from these are the invasive things like a DSA, which can also differentiate between a global hyperemia and this thing, or a MR angio or CT angio if we have this.
Okay. Okay. So
Punaya,
we do
can I
get
make a
the patient post-operatively. So I'll just present what happened to this patient. So you're able to see my slide?
Yeah.
Are you able to see my slide? Yeah.
Yes, yes.
Okay. So this patient was on noradrenaline, and as I told, the monitor looked okay with a heart rate of 72. BP was fine, saturation was okay, although with 60% FiO2, a CVP was on the higher side, but her urine output decreased and the lactate was keeping on in the rising trend. So as the experts did, we should use a specialized monitor. So when we used a continuous cardiac output monitor, this was the picture we got, everything in yellow, okay. SVR was high, the stroke volume, cardiac output, cardiac index was very, very low, although the SVV, the volume status was good, which was even shown by the IVC diameter. So we started her on dopamine. And what happened next was this: there was tachycardia, the monitor was not looking okay, but the SVV increased to 19%. So a lot of fluids were given and the SVV was brought down. And what happened next was a very good urine output and everything optimized later on. With a good stroke volume, SVR was came to normal range, the cardiac output, cardiac index raised, and the SVV was within normal range.
Yeah.
And 1 month later, she had a very good functional outcome. She came out very well, and now she's into her normal routines. And 1 month later, I repeated the echo. The echo was absolutely normal. So, what I want to stress the residents and trainees is that neurogenic myocardium, the stress cardiomyopathy, acute pulmonary edema can happen in these kind of scenarios, which is more common in subarachnoid hemorrhage and traumatic brain injuries. And sometimes they ask me, the surgeons ask me, do you need to get a cardiology opinion for that? What is your opinion on this, Manish? Do you need to get a cardiology opinion for these kind of patients?
We may need a cardiologist opinion to rule out if there is actual myocardial infarction or not. But other than that, I say that we do not need cardiologists to help us. They can do a good echo so that we want to.
No, he said legally to do something with it because patient has got a cardiac dysfunction. Should you get a cardiology opinion? Because this is a known thing, known phenomenon, known physiology.
See,
and manage.
Say a cardiologist can do a good echo so that we can come to know about some parameters. Other than that, for managing such a patient, we do not need a cardiologist.
Okay, Dr. Virender, your take on that? Do you involve a cardiologist in these kind of patients, or you manage yourself?
See, basically again the same issue. The cardiologist, they'll be involved at some point of time. Suppose in a private setup, they'll be involved at some point of time. But it is as a primary intensivist, it is your duty that at what stage their intervention has to be stopped. And so that thing has to be taken in care, that it is primarily your patient and you have to decide what management will go with. So it is like some good echo is required, some hemodynamic parameters and some investigations that the cardiologist can help. And if some future, maybe they can help us, but not in the primary management of these patients. They should not be involved.
Okay. And Dr. Prasanna, a question to you
Yeah,
from our own Dr. Saurav.
yeah.
If the patient has two aneurysms and one is still unsecured, will you still go for hypertension in the postoperative period when the patient is having cerebral vasospasm? I think you shared a few words on this, but can you explain that in detail? An unsecured aneurysm in the event of
Yeah.
postoperative vasospasm. The patient has two aneurysms and one is unsecured. And postoperative period, patient developed vasospasm. How do you go
Okay.
about that?
No, definitely I'll not go for induced hypertension. I'll go for other interventional parameters. Maybe if the patient is clinically symptomatic, I will definitely do not go by a single parameter of a TCD if the patient is clinically neurologically stable. Okay, so if I see the TCD values are increasing, definitely I look into again my fluid status at least and the BP of the patient. If the BP is same as a pre-op period and the fluid status is all right, then if the patient neurologically I find she is deteriorating, then I'll
So
go
you
for
can
other
go for
interventions.
other measures like
Intervention. Yeah.
angioplasty and
Yes. Yes.
intraarterial nimodipine or
Yes.
intraarterial milrinone and things like that. And
Yes.
coming to the point, how about milrinone, using milrinone for cerebral vasospasm? Because there was a question they asked, apart from nimodipine, what drug you use?
I
How
think
about your experience on
I
using
think
intraarterial or intravenous nimodipine? Dr. Virender, please. Yeah.
I think Mineralon has been extensively used and it has been found to be useful. The only thing is it has to be the expertise used needed to use such a drug has to be there. And I think Medanta people, they have quite a lot of experience using the Mineralon, and they have been quite successful in managing such patients. We
No,
do not routinely use Mineralon at home.
even at global here, we have used a lot of milrinone, intra-arterial milrinone as
Mineral,
well, and we maintained it with a
yes.
post-operative intravenous milrinone. It has produced some good results, but we still need very great evidence to recommend to others. But this is also a therapy which can be utilized to revert the cerebral vasospasm. If you could
There are
set up.
two more questions in this thing. One is, I think Prasanna will answer the role of etomidate in the induction of hypovolemic patients. And the other is by Dr. Anil Parak. Can plasma lights be used as normal saline for intraoperative fluid management?
Yeah,
Prasanna,
Dr. Prasanna, please.
can you answer
Plasma
on
light
this?
instead of normal saline and role of etomidate in inducing these kind of patients.
So in a patient with a poor heart, maybe a known case of coronary artery disease or unstable heart, definitely I will use a etomidate for induction of anesthesia.
Okay.
There is no doubt in that. And there are some papers saying that etomidate provides cerebral protection also. It has been Ravus et al. Compared propofol and etomidate for the cerebral protection. There are papers say that etomidate has a role in cerebral protection. So I would definitely use that method. But there are not many papers which have used this plasma light in place of normal saline or ringer lactate to say that one is superior over to the other. It is still. But considering its composition, definitely I will use plasma light if it is available to me.
Okay.
I cannot say guarantee that it will make matter in improving the outcome. It is very difficult to predict considering there are so many confounding factors and intricacies in the intensive management of these patients. So definitely I would like to go for that.
And Dr. Manish, you'd like to add anything?
The plasma light we are using whenever we have to give large boluses of fluids. But again, there is no strong evidence, but it makes sense because it looks to be more physiological. That's it.
So much of the papers on plasma light or on trauma patients, and there are papers in renal failure patients also regarding the use of plasma lights. We have been using in elective neurosurgical operations of late, using the plasma light. But as of now, it is very premature for me to tell that plasma light will replace NS or RL as of now.
Okay. And there is a response from Saurav. He says that the guideline says that you can induce hypertension even if there is a unsecured aneurysm post-operatively in case of a multiple aneurysm to prevent in the scenario of vasospasm.
I agree with that.
Is it?
Okay, Manish, can you shed more light on that? Yeah.
See, vasospasm is life-threatening. If there is clinical presence of vasospasm, the patient is down neurologically, then it needs to be treated first, or it needs to be handled first. The rupture of second aneurysm, in case there is increased blood pressure, is a bit hypothetical, and we don't know the exact incidence what it would be. So that we need to tackle the problem in hand first, and then we can think about anything else.
I think Dr. Anil Parak has joined our call. Sir, can you hear me? Hello? Sir, can you hear me?
Hello.
Yeah, I can hear you, sir.
Yeah, I can hear you.
Yeah. Please go ahead, sir. What is your...
I don't have any question now, but yeah, I can hear you.
Yeah, we are able to hear you, sir. Yeah. Please go ahead, sir.
Yeah.
Sir, kindly mute your YouTube volume so that it doesn't interfere with us. Yeah.
Probably his network is weak.
Yeah. Okay. So, Manish, can you go ahead with that? Yeah. So you mean to say hypertension can be induced in spite of having an unsecured aneurysm? No, but why don't we go for alternative, definitive therapies like angioplasty or intra-arterial nimodipine or milrinone instead of inducing hypertension? If at all you induce hypertension, what will be your target? Will you go till 180, 200 systolic, or you would limit to a specific value?
What we usually use is 20 to 30% higher than what the baseline is.
Okay.
So many times.
Go for extreme hypertension.
No, we usually do not.
Okay, so I think in clinically, practically, in most of the scenarios, the patient will be taken for other modalities like angioplasty or intra-arterial nimodipine and stenting.
But like withholding hypertension for this reason is probably not right.
Okay. Dr. Anil, sir, can you hear us now?
Yeah, I can hear you.
Yeah, we are also able to hear you. Go ahead, sir.
No, I just wanted to congratulate your full team for the great initiatives you have taken.
Thank you, sir.
And I think every month we should plan like that.
Sure. And, every month, not every week we are planning. Don't worry, sir.
Thank you, Anil. And we'll join you next time.
Yeah, sure. Thank you so much for coming, sir. Yeah.
Thank you. Bye.
Okay. So.
Any more questions?
If there are no more questions, then we have come to the end of this presentation. I really thank Dr. Prasanna for his wonderful presentation. It was very great, and you had made a lot of efforts to do this presentation. And I thank Dr. Virendra Jain for sparing your time at a weekend. And I saw you disturbing you in between. And Dr. Manish, thanks for joining us. And unfortunately, because of the network issues, Dr. Indranil was not able to join us. Anyway, in the future classes, we'll be inviting more and more experts throughout the national and also internationally. We'll be able to get the experts, and I think this initiative is going to go a long way. And if you have any suggestions or feedbacks, kindly follow us on Facebook page Classroom. Inbox your message, inbox your opinions, inbox your feedback, and I'll be very grateful for that. And till the time we will meet the next week or the next session. Goodbye from everybody else. Yeah, Dr. Virendra, go ahead.
Also, the suggestions can be posted on the ISNAT WhatsApp group. I think that's a very good initiative that has been started.
Yeah, that suggestion also we will take.
Can also be started.
Yeah. So my sincere apologies if there are any hitches or hiccups in this presentation, because this is the first time we are doing that. We will be reviewing our YouTube video, and don't worry, if at all your friends or anybody have mixed this video, it will be uploaded in the YouTube, and I'll share the link. In the next few weeks, you can expect topics from us ranging from hypothermia, anesthesia for intraoperative functional neurosurgery, and anesthesia for epilepsy surgery, anesthesia and MRI suit. These are the recent topics which are going to come. So stay tuned to Classroom. And thank you, everybody, and have a great week ahead. Thank you.